Resolving Interprofessional Conflict in Advanced Practice Nursing, an Interest-Based Relational Approach, from Learning Team 5, Leila Cervantes, Mirella Garcia, Lauren Garza, Jennifer Martinez, and Blessy Zaula. We have 4 main objectives within this presentation. First, we're going to start by describing the interprofessional conflict in our APRN case study, really laying out what happened, who was involved, and why the conflict developed. Second, we'll explain the key principles of the interest-based relational framework, which is the approach we're using to understand and address the conflict. Then, we'll apply the IBR framework directly to the case, walking through how it helps analyze the situation and guide resolution. And finally, we'll evaluate how effective this approach is, including its strengths and also its limitations in real-world APRN practice. Roger Fisher, professor of law, and doctoral student William Ury developed a conflict resolution framework designed to guide everyday negotiators through conflict in a way that preserves relationships while addressing underlying interests rather than positions. Fisher and Ury published their book, Getting to Yes, Negotiating Agreement Without Giving in 1991, and although it has undergone many revisions, the model stands today and is often referred to as the Interest-Based Relational Approach, or IBR. The IBR approach includes separating the person from the problem, keeping the focus on interests rather than positions, listening actively to embrace shared goals, collaborating on mutually beneficial solutions, and using objective criteria rather than emotion to ultimately maintain the professional relationship while reaching a consensus where both parties feel heard. Fisher and Ury's model recognizes power differences which APRNs will ultimately face in the workplace. Their model is designed to navigate negotiation techniques even if one side is more powerful than the other. It helps support the suggested ANA conflict resolution strategy of collaboration, which involves the objective evaluation of different views, leading to compromise and new ideas. This framework is based on negotiation rather than bargaining. While bargaining is rooted in taking sides rather than finding common goals, negotiation is rooted in placing common interests above positions and coming to a mutually beneficial agreement. The following case study involves a scope of practice conflict between the APRN and her supervising physician. The setting is a primary care rural health clinic, and the key players involved are the APRN, her supervising physician, and the patient. The APRN is an appropriate negotiation leader in this scenario because she functions as a directly involved member in the conflict and understands its clinical implications. She possesses advanced communication and leadership competencies. She has the responsibility to advocate for safe, timely patient care while maintaining collaborative relationships. She's trained to use evidence-based decision-making and professional negotiation strategies, and she functions at the intersection of clinical care, collaboration, and coordination. Jane Ellis, a certified family nurse practitioner, works at a Texas primary care clinic under a signed prescriptive authority agreement that outlines which medications can be prescribed independently and which require consultation with the physician. Jane evaluates a patient with uncontrolled chronic pain who meets evidence-based criteria for a non-opioid neuropathic pain medication. Jane prescribes the medication in accordance with current clinic guidelines on permitted medications and within state APRN authority. Later that day, the supervising physician messages Jane stating, "I've had bad experiences with that med and I want you to run those types of prescriptions by me before prescribing." Jane reviews the agreement and confirms that the medication is within the delegated prescriptive authority and no consult is required under the written protocol. She is concerned that the doctor's expectations are ambiguous and will ultimately delay patient care if she must wait for prescribing medications until he is consulted. The conflict lies in the physician preference versus the written delegation agreement.
The interest-based relational framework guides the APRN's approach to the situation with the physician. First, separate the person from the problem. Instead of assuming the physician doesn't trust her, Jane can reframe that as a possible misunderstanding about prescribing expectations. Patton, Fisher, and Urey identify the importance of seeing the situation from the other perspective as paramount to successful negotiation. This reframing prevents defensiveness and keeps the focus on the issue, which is patient care and safety. The second step is to identify the player's position relative to the interest, because the conflict lies in the position, not the interest. When the position is the focus, ego is introduced, and the likelihood of any mutually agreeable negotiation at that point is significantly reduced, as the focus on the party's actual interest becomes clouded. In this case, the physician's position is that he wants to be consulted before prescribing a certain class of medications. The APRN's position is that the delegating agreement and scope give her authority to prescribe this class of medications. The physician's interest is patient safety and liability, while the APRN's interest is also patient safety, efficient care, and understanding their role and scope. In the third step, goals are verbalized, patient safety and ensuring they're practicing within their guidelines. Jane can shift the conversation to focus on the collaboration of patient care and their shared goals for the patient. Step 4 involves collaboration. This is a time to involve joint decision making. Jane asks the doctor if they could create a list of medications that he wants to consult on so that she is clear on what he is comfortable with and he feels that she is hearing his concerns. She then suggests establishing clinical thresholds. This will let the APRN know what criteria determine the action the doctor expects. It helps her answer, when can I act independently and when do I consult? Removing ambiguity can help prevent conflict. The APRN will, in Step 5, discuss the issue using neutral references, such as a delegation agreement, state law, and clinical guidelines. Objective data and standards may be more acceptable because they present the data as scientific and fair and set an impartial precedent to follow. Use of state law and delegation agreement language can support decision making without introducing emotion. Lastly, Jane's goal is to maintain the working relationship with the delegating physician. She ensures this through her tone and delivery. I want to ensure I am practicing exactly as you would expect within our agreement. Can we review this together? This delivery respects authority while inviting partnership. Jane wants to solve the conflict without damaging the working relationship. She still has to work with the physician in collaboration, coordination, and communication. They rely on each other professionally, and is in both their interests to maintain the relationship. The IBR framework encourages the negotiators to consider 3 ideas to maintain the relationship. 1. Perception, putting yourself in their shoes. 2. Emotion, recognize your feelings and theirs. And 3. Communication, show active listening, respect, use of I statements, and refrain from responding to emotional outbursts.
When Jane and her supervising physician identified each other's interests rather than getting hung up on the other's position, they were able to collaborate to create a medication checklist for consultation, clinical thresholds, and protocol lists that clearly defined situations that called for either consult or allowed for autonomy. It meant that Jane could now practice more independently with a clearly defined role that allowed for both autonomy and collaboration. Even though she agreed to consult on medications not legally required in each state's scope and guidelines, she understood the prescribing physician's view and agreed with their goal of patient safety. The plan also kept the physician involved in the leadership and consultation for what he considered complex care that required expertise. Though he is in authority over the APRN, her ability to negotiate in a way that prioritized interest over position and her presentation of objective criteria helped him trust that she was aligned with his goals. Ultimately, the framework improved access and care for the patient in question by ensuring a collaborative approach. This ensures adherence to the ANA Code of Ethics Provision 8, which encourages nurses to build collaborative relationships for the greater good, as well as ANA Provision 6, which calls for maintaining a collective effort within the work environment.
Jane and the physician are able to use the IBR approach to clarify each other's concerns and work collaboratively to promote both their goals of maintaining patient safety while avoiding delays in care. This dynamic strengthens their professional relationship rather than creating power imbalances and territorial issues. By focusing on shared outcomes, solutions become more patient centered, evidence based, and sustainable long term. For Jane, using the IBR framework also helps advance her communication and leadership skills, aligning with the APRN role. There are some limitations that may have led to a different outcome. If the physician chose to use his authority, negotiations may not have been equal. IBR framework also takes time to work through. Therefore, this method may not work in urgent clinical situations. And lastly, both parties have to be willing to listen, maintain professionalism, and be willing to compromise.
This example of the IBR framework helps people handle conflict by focusing on the real issue, understanding each other's needs rather than arguing over positions, working toward shared goals, and keeping relationships professional and respectful, even when there are power differences. The presented case study shows a disagreement about the scope of practice in a rural clinic that employs the APRN alongside a supervising physician to address the conflict and advocate for safe, responsive patient care using clear communication and evidence-based practices. The APRN prescribed a medication that was clearly allowed under the signed prescriptive authority agreement and within Texas regulations. However, the supervising physician requested prior approval based on personal preference, not the written protocol. This created confusion about the role expectations and led to a delay in patient care. The conflict arises because the physician's personal preference does not align with the written delegation agreement, underscoring the need for clearer role expectations and open professional communication. Using the IBR approach, Jane can shift the conversation away from authority and toward the goal of patient safety. By reviewing the agreement and establishing expectations, they can clarify when consultation is needed and develop clearer prescribing guidelines and collaborate together. To develop a resolution, Jane and the physician work together to create a checklist of medications that require consultations, establish clinical thresholds, and also create prescribing protocols. The clinical guidelines and professional standards that are set help reduce misunderstandings and focus on patient safety. Collaboration between the two professions not only protects liability for both, but also keeps the APRN within the scope of practice and promotes consistent, safe, timely patient care. Using the interest-based relational approach helps Jane and the physician focus on their shared goal of patient safety rather than on differences in authority. This approach strengthens interprofessional collaboration and supports professional communication. Power imbalances can influence the negotiation process. For this to work, it requires time, active listening, and professionalism. In a fast-paced clinical environment, or when collaboration is lacking, this framework may be difficult to implement. Roger Fisher has been open in the past about limitations concerning this framework, but states that this model is useful when you are concerned more with how conflict should be approached and less with how people normally deal with conflict. As advanced practice registered nurses, our goal should be to encompass the code of ethics we subscribe to, and that includes collaborative efforts to achieve the greater good.